So now we're going to go to our third plenary. And I'm particularly excited about this one. I feel like this is the plenary where we're really going to kind of get into how technology can inform body-mind, mind-body connection, right? So I think that the mind-body connection, like arguably, is like one of the most important cornerstones of integrative medicine and health, or all medicine and health, right? And so I think thinking about this intersection of the mind-body connection and technology and how one can really inform the other, like really thinking about this bidirectional intersection, right? So how technology informs mind-body, how the mind-body can inform the technology. So I want you guys to be thinking about kind of that bidirectional relationship as we go through our talks today. So the first talk that we have is going to be by Dr. Vitaly Napadow. Let me give you a brief introduction here. So Vitaly Napadow is a professor of physical medicine and rehabilitation, as well as a professor of anesthesiology at the Harvard Medical School. He's also the director of the Scott Schoen and Nancy Adams Discovery Center for Chronic Pain Recovery at the Spaulding Rehabilitation Hospital and the director of the Center for Integrative Pain Neuroimaging at the Martino Center for Biomedical Imaging at Massachusetts General Hospital. Dr. Napadow's research has applied human functional and structural neuroimaging to understand how different brain circuitries modulate pain perception. And his research really aims to better understand how non-pharmacological therapies, from acupuncture and transcutaneous neuromodulation to cognitive behavioral therapy and mindfulness meditation training, how those can help patients with chronic pain and ameliorate the aversive perceptual states of pain. And he really comes at this from a unique perspective, because not only is he a pain neuroimaging researcher for more than 20 years, but he's also trained in traditional Chinese medicine and acupuncture, and is the past president of the Society for Acupuncture Research. So please join me in welcoming Dr. Napadow.
Thank you very much for that introduction, and it's a real pleasure to be here with you all. Let me just make sure everything is working. Yes, great. So first, some disclosures. Consulting and Scientific Advisory Board for Cala Health, which is, I'll be talking about a product that they have licensed that we have patented in the lab. So I want to start by talking a little bit about the rhythms of the body. And respiration is something I've been interested in a while. And one interesting thing about respiration is that it's somewhat part of the autonomic nervous system, but really it has both an automatic and a volitionally controlled aspect. We don't have to think about breathing and we will still breathe, but we can also think about breathing and change our respiratory depth, our respiratory rhythms, and all these factors around respiration. Now, in the brain, specifically in the brainstem, there are these pattern generators, these central pattern generators that will initiate the breathing cycle. And if we look specifically where in the brainstem this is located, information from chemoreceptors, mechanoreceptors comes into an area, a nucleus called the nucleus tractus solitarius, and this is the dorsal aspect of the brainstem. And this region interacts with areas such as the Botzinger and the pre-Botzinger nuclei, which are the central pattern generators for breathing. These are the important nuclei that command the body to, initiate a breath. And I'll be talking about these areas during the course of this talk. Now, one really interesting thing is that there's this bidirectional interplay between neurophysiology, brain activity, and respiration. So neural activity can generate respiration, as I just talked about with the pre-Botzinger nucleus, but also respiration can induce synchronized neural oscillations across large areas of the neocortex. And this is not just, as you would think about, the olfactory bulb, which processes smell information when we do breathe, but it's also areas that have nothing to do with smell or putatively respiration altogether, such as the somatosensory cortex, which also shows synchronized rhythms relative to respiration. So this isn't just in rodents. This is also can be seen in humans. So with intracranial EEG or IEEG, investigators have found that activity in some of these sensors in the brain are also synchronized to the respiratory rhythm, not just in it's called the piriformis cortex, which is the olfactory bulb in humans, but also areas such as the amygdala are showing some sort of entrainment to the respiratory rhythm. And there's consequences of that. There's, for example, memory retrieval and cognitive aspects, which are shown to be better if a cue is delivered during specific phases of the respiratory cycle, which is actually really interesting and needs to be followed up on. But also, consciously controlled changes in respirations are known to affect cognitive and emotional states. And slow, deep breathing, for example, has been known to reduce stress. And this is a big part of mindfulness meditation and different kinds of meditative practices. And so the idea that respiration can be somehow used as an intervention for improving clinical outcomes is something that's been around for a very long time, actually. And so one research question we had was, can respiratory rhythms be used to enhance the effects of an existing clinical therapy, for example, with neuromodulation? And this is where kind of the high tech comes into the soft touch. So first of all, there's respiration links and this idea that respiratory rhythms can be important for clinical outcomes has been a big part of Chinese medicine and acupuncture. So respiratory rhythms have been mentioned as important for acupuncture needling. In fact, the Huangdi Neijing, which is one of the oldest texts around Chinese medicine, talks about when an exhalation is completed, insert the needle. So the idea that you can monitor the respiratory rhythm and based on the respiratory rhythm, do acupuncture in order to activate or in order to enhance clinical outcomes. The question also is, whose exhalation is completed? Is it the patient's exhalation or is it the practitioner's exhalation? That actually goes unsaid in this ancient textbook, but can also have important consequences, I think. So research in this field, I think dates back, this is what got me interested. In 1997, there was this paper, it's actually a very prominent acupuncture research group from Japan, but they did this work in Canada. So Nishijo is a very famous Japanese acupuncture researcher. And what they did is that they actually did this. They did electroacupuncture stimulation at body locations during different phases of the respiratory cycle or during continuous stimulation and found that there was in fact improved pain outcomes when the stimulation was synchronized to the respiratory rhythm. And so I got interested in this and thinking about how does this then impact with not just acupuncture, but from a broader standpoint, neuromodulation. And just some definitions here. Neuromodulation is the alteration of nerve activity through the delivery of electrical stimulation or chemical agents to targeted sites of the body. And so there's been a real proliferation of neuromodulatory devices that's out there, both in the commercial and the medical sphere now, that really started from this idea of electroceuticals. So instead of pharmaceuticals, we have electroceuticals. Can we use electricity as a way to heal the body? And so there's obviously lots of these stimulators that are out there. I've been most interested in stimulators that are targeting the vagus nerve and vagus nerve pathways, so-called vagus nerve stimulation. And that's kind of where I'm going to pivot this talk to now in talking about this. But the idea that acupuncture is actually, I think, a component of neuromodulation and vice versa is, I don't think should be a very controversial point, but it's something that is not, I think, widely understood, both in the acupuncture world and in the neuromodulation world. And so this paper that was published fairly recently kind of tried to talk about that and this idea of an overlap between acupuncture and neuromodulation. And both fields really have something to learn from the other. This idea of target engagement, which is really important in the neuromodulatory world to make sure that you're engaging and targeting a specific nerve or a specific part of the body, is something that I think acupuncture needs a little bit more of in its clinical practice, but also vice versa. There's been so much acupuncture research that's been published, and the people in the neuromodulation world, they don't necessarily understand how much research has actually been done for acupuncture. And this knowledge base, I think, should be sort of exported to some of these companies that are developing devices in this field. So vagus nerve stimulation, this is something that's been FDA approved for epilepsy and even, I think, major depression, treatment-resistant major depression, but has been tried in research studies for a whole host of other conditions. And part of the reason why that's the case is that the vagus nerve really targets so many different organs. You can see the vagus nerve over here and how many different visceral areas of the body it targets. And also, you know, in the brain and in the blood vessels that are feeding the brain, there's a lot of vagus control over a lot of parts of the body. And so with vagus nerve stimulation, there's a pacemaker-like device that gets implanted, a lead that comes out of the pacemaker device, and is wrapped around the vagus nerve in the neck as it goes through the neck in the carotid sheath. And however, vagus nerve stimulation is an invasive procedure. There's a surgical procedure involved, and this has significant side effects, potential surgical morbidity. And so its applicability is kind of limited. And so the idea is that we need to develop and optimize a non-invasive form of vagus nerve stimulation if this is really going to scale and reach out to a lot of different potential patients that could benefit from this technology. So interestingly enough, there's a branch of the vagus nerve that exits out to the ear. This is called the auricular branch of the vagus nerve, or the ABVN. And so this is a way that you can much easier gain access to all of the circuitry that are then targeted by the vagus nerve. And so in this cadaveric dissection study that's dating back over 20 years at this point, what they found is that this part of the brain, this part of the ear called the cymba concha, which is right over here, is most commonly innervated by the auricular branch of the vagus nerve. So just to see like where is the cymba concha, this is where it is in the ear. And so there's a lot of devices that are being developed to target this part of the ear because it's innervated by the ABVN, the auricular branch of the vagus nerve. Recently, we just published a study with collaborators in Tennessee showing that in a rodent model, the same neurons that are processing information from cervical stimulation, the vagus nerve itself, are also responding to stimulation from the ear, from the cymba concha in the ear, which is really important, suggesting that the NTS is indeed receiving information from the auricular branch of the vagus nerve. So the NTS, the nucleus tractus solitarius, which is the first sort of gateway of vagal information in the brainstem, is also a key node for something that's called respiratory sinus arrhythmia. And this is a normal phenomenon. This is just the idea that every time we breathe in, our heart beats a little faster. Every time we breathe out, our heart beats a little bit slower. This is normal, and this is called respiratory sinus arrhythmia. And the idea here is that inspiration leads to a decrease in thoracic pressure, and which leads to an increase in venous return, increasing baroreceptor firing that then leads up to the NTS. And because of this inhibitory connection between the NTS, which is the afferent center for the vagus, to the efferent center of the vagus, or the nucleus ambiguus, that sends, you basically slow this down. And so this is vagal information down. And so the heart rate speeds up every time we breathe in because of this feedback loop. So vagus nerve traffic is normally in synchrony with respiration. And this is kind of what gave me this idea to try to link vagus nerve stimulation itself to the respiratory rhythm. And so in our approach, we gate ABVN stimulation to the respiratory rhythm, and we call this respiratory-gated auricular vagal afferent nerve stimulation, or RAVANS. And one of the advantages here is that compared to continuous transcutaneous auricular VNS, gating stimuli produces irregular stimulation, which mitigates the habituation in the NTS. This is a very important aspect of neuromodulation, is that if you just keep hammering something with electrical stimulation, eventually the body kind of compensates and you lose the effectiveness of this electrostimulation. But the other advantage is that RAVANS transmits afferents to the NTS during a receptive or facilitatory state. And this happens to be during exhalation. So there's actually not just information passed from the NTS to these respiratory drive centers like the Pre-Botzinger complex, but it also goes back the other way. And so during different phases of respiration, you have these inhibitory or excitatory links to the NTS. And so you have this like window of opportunity during the respiratory cycle that if you pass information, if you pass electrical stimulation during that window, it could be more effective. And so in our imaging studies, what we've done is we've actually compared what happens if you deliver vagus nerve stimulation during the exhalatory phase versus during the inhalatory phase, versus a control where we just stimulate during the exhalatory phase, but we stimulate the earlobe, and the earlobe is innervated by the greater auricular nerve. That's the GAN over here. And so this was another control. And so what we found, first of all, is that stimulation in general happens to be much more effective if it's provided during the exhalatory phase than during the inhalatory phase. And the differences we see between the RAVANS or the symboconscious stimulation versus the earlobe stimulation, the greater auricular nerve stimulation, is that the location of activation happens to be a little bit different, a little bit more medial, a little bit more dorsal, where it's like more consistent with nucleus tractus solitarius versus this other nucleus called the spinal trigeminal nucleus, which takes in all the information from the face and the head. And so we think that it is more effective to provide vagus nerve stimulation during the exhalatory phase. And so if we directly contrast exhalatory stimulation versus inhalatory stimulation, again, we get this really nice response in the nucleus ambiguous as well as the NTS, which is really nice. And also, it's not just in the NTS. If we look at some of the important nuclei for noradrenergic and serotonergic drive in the rest of the brainstem, you also see much better activation if you provide stimulation to the symboconcha or E-ravens during the exhalatory phase compared to both the inhalatory phase and to just providing stimulation to the earlobe. So there is a difference between stimulating the earlobe and stimulating this other part of the ear that you can really see not just in like NTS, but also further up in these really important neuromodulatory nuclei, such as the RAFI nuclei, which provides serotonergic drive to the rest of the brain, or noradrenergic drive from the locus coeruleus. So we also, in another study, we looked at the effects of different frequencies. Frequency is also a really important parameter in neuromodulation and electroacupuncture and also in RAVANS. And we found that actually providing stimulation at 100 hertz was most effective in activating the NTS, nucleus tractus solitarius, even though the stimulation parameters were completely equal between all of these different frequencies. And this was also the case for RAFI nuclei, serotonergic drive nuclei, also locus coeruleus, and also the PAG. We found the best response generally happened to be if we provide stimulation at 100 hertz. And it's for this reason that all of our sort of subsequent clinical population studies have been with this frequency of stimulation. So just to give you a really neat example of some work we've been doing in terms of applicability, in this case, it's for patients suffering from functional dyspepsia, so FD or functional dyspepsia. And so these, we've been evaluating not just brain response in these patients, but gastric response in these patients. And we actually came up with a novel way to track gastric response using MRI. And so this is the work of Roberta Skloko, who's a junior faculty in the lab. And so what we do here is we feed these patients a pudding made with pineapple. That's why there's this really cute pineapple over here. And pineapple is really interesting because pineapple is very high in manganese. And manganese is a slightly paramagnetic mineral that we can safely consume through pineapple. And it lights up nice and brightly because of its paramagnetic content when we image the stomach. So you can actually use MRI to get 4-dimensional or 3-dimensional plus time information of how the stomach is contracting over time. And so we use this as a kind of a non-invasive way to track stomach physiology, which actually is quite novel in the gastroenterology field, and they're all very excited about it, all these gastroenterologists. So this is an example of some of our imaging, and you can see the red outline is basically the stomach, and so you can see how the stomach nicely lights up when it has this pineapple pudding inside of it. The yellow outline is basically the air that's around the upper part of the stomach, the fundus. And what we can do then is reconstruct this. And if you look at it over time, you can actually see how the peristaltic waves progress through the stomach and push the contents there down to the pylorus. And so these are, you can see examples of these waves, as they're moving through these like dynamic contour displacements and passing through. And there's many interesting analyses that you can do from this kind of information. Because normally gastroenterologists don't have this at their disposal. They use cine X-ray, for example, which is just a 2-dimensional method to track how the stomach is progressing over time. And so here's an example of a plot and how you can actually see the peristaltic waves coming through. So time is over here on the x-axis, and cross-sectional area is on the y-axis, and you can see how the peristaltic waves come through. And then you can have all these really interesting metrics that you can look at, not just the speed of peristalsis, which you can get from what's called electrogastrography, just by putting electrodes over the abdomen, But you can also look at things like velocity of what's the velocity of the contraction, because you have this area, you have this measurement of cross-sectional area in the stomach as well as time. And so what we found is that those individuals who do suffer from functional dyspepsia have reduced propagation velocity in their stomachs compared to those who do not, compared to healthy controls. And when we contrasted then stimulation, because we can do these experiments with stimulation on board, when we have RAVANS, transcutaneous auricular VNS there, we then can increase the propagation velocity. So this is potentially a really important metric that you can see even during the course of a stimulation visit. And then the next question, of course, is what happens over time? If you can provide this longitudinally, what happens over time? And so that's something we're going to be tracking in a study that we just got funding for. And the study is actually very similar to the design that Franny Marin just talked to you guys about, where we're combining RAVANS, vagus nerve stimulation, with mindfulness meditation. So we have an MBSR protocol, and we have a 2x2 design where patients, in this case with migraine, are randomized to one of 4 different arms, either TVNS with mindfulness meditation, or sham TVNS with mindful meditation, or TVNS with an education control. So now we're controlling for the MBSR, or both controls over here. And the idea here is that there's going to be synergistic effects when we combine an intervention that has a lot of respiratory component to it, like mindfulness meditation training, with a neuromodulation technique that is specifically geared for targeting with respiration. So if we use the respiratory rhythm as kind of this anchor around both the mindfulness practice and around the neuromodulation, will we get a synergistic effect? That's kind of the question we've been asking, and we just recently completed this study. So in conclusion, auricular VNS targets the NTS in the brainstem. Neurophysiological activity through the brain is entrained by respiration and also motivates respiratory-gated neuromodulation approaches, which can be enhanced when we provide RAVANS TAVNS stimulation during exhalation. And RAVANS TVNS also upregulates serotonergic, noradrenergic activity in a stimulus-response fashion. And RAVANS can potentially modulate gastric function in functional dyspeptics by increasing accommodation, peristalsis, and emptying, as well as other potential applications such as chronic pain and migraine, and perhaps other clinical applications as well. So I want to thank you all for your attention. I thank my collaborators, both at the Martino Center, at the Spaulding Rehabilitation Hospital, and in gastroenterology with Brad Kuo, and of course support from the NIH and NCCIH and KIOM in Korea for assisting us with these studies. Thank you very much.
Thank you so much, Vitaly. So interesting of the vagal nervous system as sort of a window into maybe that mind-body connection, and then using it to augment a mind-body practice. All right, so if you have questions for Dr. Napadow, we'll save all the questions until the end when we do our panel discussion and QA. So the following 3 short talks we have, 4 speakers, 3 talks. So the second talk will have 2 tag team speakers. So I'm going to go ahead and just give you the introduction to all of our speakers so that we can just go through the talks efficiently. All right, so our next talk will be Dr. Brad Manor. Dr. Manor is the director of the Mobility and Falls Research Center at the Hinda and Arthur Marcus Institute for Aging Research at Hebrew SeniorLife. He's an associate professor of medicine at Harvard Medical School and also practices at the Beth Israel Deaconess Medical Center. And Dr. Manor's research really links brain function and balance and falls in older adults. And he focuses on designing interventions like Tai Chi and mind-body movement to improve balance by optimizing brain function and exploiting its adaptive properties. Then we're going to have Dr. Peter Wayne and Dr. Giulia Corniani. So Dr. Wayne, as you've met, is our director of the Osher Center. He's the Bernard Osher Associate Professor of Medicine in the field of complementary and integrative medical therapies at the Harvard Medical School. And Peter has, more than 45 years of training experience in Tai Chi and Qigong. He's an internationally recognized teacher of these practices and also a leading researcher in the field and my partner in all of the research that I do. Dr. Giulia Corniani is a postdoc research fellow at the Harvard Medical School. She does her research in the motion analysis lab within the Spaulding Rehabilitation Hospital. She's PhD trained in computational neuroscience, and her research focuses on applying machine learning and deep learning methodologies to develop therapeutic solutions for clinical settings. So please welcome our first talk, Dr. Manor.
Hi, everybody. Honored to be here today to tell you a little bit about our journey in using technology to study human gait and why normal gait and dual task gait in particular might be particularly helpful in thinking about mind-body interventions and how and why they work. I have no disclosures other than I'm kind of a nerd and I think a lot about how we walk, why we walk, how we should measure it. In order to walk, we have to maintain our body's center of mass, which is located way up, about 2/3 of our height off of the ground, over our base of support, which is constantly moving. And we do this with a very complex system. We typically think about our muscles and our reflexes, but it goes beyond the peripheral neuromuscular system, right? In order to walk, we have to pay attention to our surroundings. We often can't see our feet, so we have to keep the position of our body in our short-term memory. And often we have to maybe make the right decision to slow down if the trail in front of us is uneven. Which means that, as we know, age and other diseases can affect gait. And those changes in walking and our ability to control gait very much come from changes to the peripheral nervous system, but also the central nervous system, including the mind. And it's much more complicated than that even, because we never just stand or walk. We're always walking and talking, or maybe walking and holding something and reading a sign in our environment, or often we're faced with very challenging situations. And you can imagine that the control system that enables us to successfully walk across the street while not hitting anybody, not stepping in potholes, selecting the right speed, is perhaps the most complex system of all. And we know from a large body of neuropsych research that if you do two cognitive tasks, walking and talking at the same time, it can disrupt, and it does disrupt performance in one or both of the tasks. So we are always what we refer to as dual tasking, and it comes at a cost to performance in one or both tasks. And we can measure the dual task cost. We can measure gait. We can measure dual task gait and how dual tasking affects gait in the lab in many different ways. Certainly, we can just use a stopwatch and measure walking speed. The most common way we measure dual tasking in the lab is have somebody walk and walk again while doing another cognitive task like counting backwards or reciting every other letter of the alphabet. So that's what we refer to as dual tasking. So we can use a stopwatch. If we're lucky, we can have a gait mat, which this person is walking over, or we can use three-dimensional motion capture. So however you measure it in the laboratory, here's one example of an individual, 82 years old. Here, they were walking on the top over a gait mat. So you can see each footfall. And this person, you can tell their stance was quite wide, probably walking slowly. They veer a little bit over the course of about 5 meters. Here's the same person walking while counting backwards by 3s. And you can see that this person very much slowed down. They're spending a lot more time with both feet on the ground. And if you really look, the variability and even the spatial parameters very much increases from one to the next. So normal gait is typically thought of, if we measure gait speed is the 6th vital sign. And if we look at dual tasking gait, it actually provides even more unique information in my mind. So we know dual task cost at baseline can predict falls, but interestingly, it can also predict the risk of cognitive decline. Here's a study of 112 individuals, older adults with mild cognitive impairment. They measured dual task performance and many other things at baseline, and then tracked them long-term for the conversion from MCI to dementia. And divided into baseline dual task cost performance of greater than or less than 20%. You can see that the group with greater dual task costs, so they slowed their gait by 20% or more, were almost 4 times more likely to develop dementia during the observation period. And I copied and pasted this because I think it's really fascinating. So dual task gait was comparable to cognitive testing in predicting incident dementia, and adjustments for baseline cognition only partially attenuated those associations. So here we have a measure of gait that's very functional, right? We are always dual tasking. It can provide really unique insights into how we move, but also our cognition and how the mind-body connection is really working in our daily lives. So that got me very interested in mind-body interventions and working with Peter and Gloria and Andrew and many others, because certainly Tai Chi and other mind-body interventions focus on movement, right? We have to shift our weight from one side to the other, muscle strengthening, but we also have to pay attention to how the movement looks and feels. We have to remember what comes next in the sequence of movements. So in my mind, this idea of dual tasking as we are walking or standing is really central to the idea of mind-body therapy. So we and others have studied the effects of Tai Chi training on gait and dual tasking. Maybe 10 years ago, we published work showing that we can improve dual task performance. Since that time, there's been work to suggest that those changes are linked to changes in brain function that's more traditionally thought of as executive centers of the brain. And more recently, there have been larger studies showing that Tai Chi over time can improve dual task performance in older adults. But certainly most of these studies to this point have been relatively small in number. And as most clinical trials, our measurements of gait and cognition come at snapshots, right at baseline, just after the intervention, and then if we're lucky, maybe one time in follow-up, which really doesn't tell us too much about the timing of the intervention, when it starts to work, how long it works, how variable it is over time within each individual. And I think that limitation really comes from how we measure gait. So I've been thinking a lot more about this, right? So if we measure gait in the laboratory, we can use the stopwatch, but that's biased. The instructions, especially dual tasking instructions, are critically important. If you tell somebody to walk and pay attention to this cognitive task and try not to get any answers wrong, that's much different than saying, try to walk as stably as you can and do this cognitive test, right? So the instructions are critically important. If we avoid stopwatches, we know that motion capture is expensive and time-consuming. And then perhaps most importantly, these measures require our participants to come to us. And so often our participants have trouble organizing and utilizing transportation. So it really sort of biases our work. And beyond just the logistics of measuring gait, we also know that measuring things in the lab is very different than measuring it at home. This is a large study where they measured walking speed on the top row in person with a research staff member. And then they also measured daily gait speed in the home with cameras. And you can see that across all individuals, there was a reduction, right? People walk much more slowly at home than they do in the lab. And that might be okay, except if it would be okay if everybody was sort of the same, right? In person versus home. And that difference was similar from person to person. But here are each of those 1,965 individuals. So you can see that some people in the lab walk quite quickly and at home quite slowly, and vice versa. So that, all of those limitations combined, has really led us to, especially during the pandemic when we couldn't bring people into the lab, has let us create a smartphone app which enables self-administered prescribed tests of both normal and dual task gait. And we can do this because the phone has internal motion sensors that are in many cases research grade. Another nice thing about the phone is that we can provide the exact same instructions to each person every single time we do the test. So the app actually starts with an animation of how to do the test. You can read and sign in a consent form if you'd like, if you want that functionality. Then you hit start and it asks the person to put the phone in their pocket. And then from that point forward, the phone switches to audible instructions to guide the person through 2 different walking trials, one under normal conditions and one while counting backwards by 3 from a random number that's given just before the trial. And during the time of the phone in the pocket, it's capturing data as they walk. That's sent to the cloud, and then we can analyze that offline. So here's just a quick example. On the top is the actual angular velocity, so the rotation of the phone. So as somebody is walking straight, right, we have a little bit of rotation, which you can see over the first maybe 8 seconds. And then the person turned 180 degrees and started walking back. So by using the angular velocity data that's rotated to the global coordinate system, we can actually capture when the person is walking straight versus turning. And when they're walking straight, on the bottom is the acceleration pattern. So how the phone is moving up and down in the axis aligned with gravity. And it turns out that there are signatures in that acceleration signal with the appropriate filtering that align very nicely with heel strikes and toe offs, which allow us to then look at things like stride time and how variable that stride time is over time. Measuring gait speed, which includes a spatial component, is actually quite difficult with a wearable sensor. But there are more and more efforts now to estimate gait speed, and it can be done relatively accurately now with using some manipulations that I won't get into. And we've done a series of about 10 validation studies to this point. So here's just an example of dual task cost measured over the gait mat in our lab versus with the phone in the pocket. And you can see that the agreement is quite nice. These numbers are a little bit small, but what we do in all of our studies is multiple assessments within a day and across days, both in the lab and then at home with the smartphone. And our test-retest reliability, so ICC values, you can see are quite strong, whether we're doing it in the lab or at home. And we've since validated this in older adults across a pretty wide range of physical and cognitive function, as well as tech savviness, and in patients with Parkinson's disease. And this allows us to do really cool things that we haven't ever been able to do before. So for example, our app now serves as a primary assessment for what's called the Barcelona Brain Health Initiative, which includes 3,000 healthy middle-aged adults, as well as the Ignite trial, which is focused on exercise intervention in older adults. So here's just a quick example of the Barcelona Brain Health Initiative. This is cross-sectional data. On the bottom is single task walking. On the top is dual task walking, just separated by age. So you can see that from 40 to 65, single task walking performance really didn't change. But dual tasking, there was an inflection point at about 55 years of age, such that seems to be the point at which our ability to dual task starts to decline. And the cool thing about this study was that all of this data was captured in a 3-week period, because we can have each of our study members download the app, consent, and do the test in their own home, and we can analyze that quite quickly. So just a few conclusions. I think dual task gait is certainly near and dear to my heart. I'm biased, but I think it's very essential to most ADLs. And it certainly depends critically on mind-body health. And I think smartphones offer a very unique way to do a very prescribed test that we do in the laboratory, but in the home. And as a result, we're very interested in using this tool to track changes. And we can do that with much higher frequency than ever before in fall risk and changes in cognition in older adults, and certainly in the timing and extent of intervention responsiveness. And unfortunately, we have not yet utilized this tool in studies of mind-body interventions, but that is certainly on our roadmap, and happy to collaborate with anybody who is interested. So thank you.
Hi, everybody. This is going to be a tag team between.
Okay, all right. So let me introduce Alessandra. All right. Yeah, we can do this on the fly. It's great. All right. So Dr. Alessandra Anzolin is a faculty member at the Department of Physical Medicine and Rehabilitation at Spaulding Rehabilitation Hospital and Harvard Medical School. She is a member of the Napadow lab, and her work bridges neuroscience, social science, and pain medicine, focusing on the use of cutting-edge techniques like hyperscanning, which she'll tell you all about, which enables the study of dynamic brain interactions during real-world social exchanges. So really very cool cutting-edge work. So welcome, Alessandra.
Thank you, Gloria, for your introduction. We're just going to take a second. Good afternoon, everybody. Okay. And this is what I use, right? Perfect. Okay. So yes, nice to meet you, everybody. I'm so excited to be here and present a little bit of our work on understanding brain mechanisms behind the patient-clinician interaction and how therapeutic alliance can be discovered more using advanced technologies such as hyperscanning, and how this can be related with clinical outcomes possibly. So let's start defining a therapeutic alliance, which is there's a very specific bond that is the specific bond between like patients and clinicians or practitioners, and is built through like a mix of verbal and nonverbal communication. And every type of positive but also negative social interaction goes into developing this patient-clinician relationship. And this is true for every social relationship in our daily life. But we are particularly interested in studying therapeutic alliance because it's been proven over the past years that is a key element in many therapies, and especially in a lot of non-pharmacological treatments, so really relevant for the field of integrative medicine. I reported here just like a few examples. We have some of the most relevant papers, like for example, here we have spinal manipulation for patients with chronic low back pain. We have psychotherapy. We have this paper from Ted Kapchak in which he looked at patients with irritable bowel syndrome. And in all those papers, what we notice is that there is a boost in therapeutic effectiveness when we have augmented the interaction between patients and clinicians. And of course, patients are our main target, but this type of study is also relevant for clinicians and practitioners because, for example, in 2020 was published this paper from Masserotti and his group, in which they reported how better communication skills and a better patient-clinician interaction are actually also associated with the reduced risk of clinicians burnout, which is another important aspect of our time. Okay, so now we understand why this is relevant and is worth in studying. The next question is, how do we unveil the brain mechanisms behind the patient-clinician interaction? It's challenging, but so let's consider any two-person social interaction, right? So both individuals are constantly reacting to each other based on like verbal and nonverbal cues, but they also come into this conversation with their own like history, motives, history, like idea or expectation of the social partner, and so on. So the vast majority of the existing literature about patient-clinician interaction investigates only the mechanisms from happening in one individual, which most of the time is the patient, of course. And so basically, this model, which is absolutely valid and helpful to understand part of what is happening in the patient's brain, is ignoring like another half of this closed loop that we represented here. And so in order to fully capture the dynamic of the entire system, what we propose, and I'm going to try to present today, is to acquire and analyze brain data from two subjects considered as a unique system. So to considering the whole dyad as the system we are analyzing. And in particular, this is called two-person neuroscience, and one fundamental part of it is called hyperscanning, which is the ability to acquire brain data at the same time from two or more people. And the other part is what we call multi-brain analysis, which is the ability to compute new novel like measurements to capture the brain concordance. So yeah, let's start from the acquisition. This is like a pretty accurate representation and illustration of our setup for our hyperscanning projects. On the left, we have the functional MRI setup. On the right, the EEG. The fMRI, of course, brings all the like spatial resolution to provide indication of the neural mechanisms involved in this interaction, as well as giving us more precise information about what are the main brain regions involved during therapeutic alliance. While the EEG brings other advantages, including ecological validity of the experiment. As you can see, they're just like one in front of the other, reproducing a pretty accurate, like a pretty naturalistic clinical intake, but also the faster dynamics in brain-to-brain activity, so we can capture more like faster changes while the two people are interacting. So this is like the first study we ran in the lab, and that was led by Michael Ellinson. At the time was a postdoc in Vitaly's lab, and includes fibromyalgia patients and acupuncturists undergoing a functional magnetic resonance hyperscanning during an evoked pain task, where we use the cuff around the left leg and electroacupuncture as a treatment. And we did run this hyperscanning visit in two different conditions. So either the clinical dyad interacted in person prior to the scan or not. And during the scan itself, like regardless of what conditions was happening before, they could see each other through like a video link, as you can see like in this picture here. So they can always like see each other. Okay, so first we looked into the patients and the clinicians' brain activation separately. And what we observed, it was like this like similar maps of activation, including a lot of the mirroring circuitry areas, such as like a ventrolateral prefrontal cortex, anterior insula, TPJ or temporal parietal junction, which will come back a lot in this presentation. And then we moved towards what we introduced before as this multi-subject analysis, in which we tried to define a new measure of brain concordance based on the trial-by-trial variability acquired from both brains, patients and clinicians at the same time. And what we found is that there is like a high brain concordance involving the same areas that we mentioned before, so belonging to the mirror circuitry, but also that only for the connection specifically involving right TPJ to right TPJ, so patient and clinician temporal parietal junction, we observed this association between a greater concordance and analgesia as rated by the patient. Okay, and so that was the first time we started understanding how actually like a brain concordance and brain synchrony is actually modulated by the presence of an interaction between the patient and practitioner. And so this brings us to our second study, which is was led by Arvina Gral, who is another like research fellow in our lab. She's still very much involved in all of our like hyperscanning projects. And here, like the question they raised from the previous study was, what does happen to brain concordance and clinical outcomes or pain perception when we intentionally manipulate the interaction between patient and practitioner. So we tested the importance of developing this relationship over a 3-week acupuncture treatment. So this time we have hyperscanning visits before and after this intervention. And also we manipulated the clinical context, like randomizing our Dyads in augmented and limited interaction. So in particular, we trained our acupuncturist, and in the augmented group, the clinician was having like long and personal conversations. Like this involves like active listening, personalized content, and yeah, of course, was very much patient-centered. While in the second group, which we call limited, the patients and the clinician were in this more neutral interaction style for the whole time of the treatment. And so what we found after this 3 week of acupuncture is that pain relief was significant in both groups. So like this proves the effectiveness of the treatment, but no difference between like related with interaction style. But for pain catastrophizing, willingness to continue to see their acupuncturist, and expectation for future pain relief, we saw a much higher effect in the augmented group compared to the limited one. So this brings to us attention that probably there is not a direct link between the interaction style and the pain perception itself, but there are so many other aspects and dimensions of the patient's experience during pain treatment related with this with the clinical context. And we continue to explore the patient-clinician interaction now using, as we mentioned before, a more naturalistic experiment, leveraging on EEG hyperscanning. And in this third study, we enrolled the low back pain patients rather than fibromyalgia patients, also to try to understand if those results was like very specific of this population or generalizable to other chronic pain populations. And also in this case, we have one single visit. So in this case, we combined altogether a clinical intake, a pain task, and also a single acupuncture treatment for low back pain. Okay, here we go. So as in the previous experiment, each dyad was randomized either in an augmented or a limited group. And in this short video, I just wanted to show a little example of one of our clinical intakes that actually happened, was one of our first enrolled Dyads. And it shows how we were able to acquire a lot of data starting from EEG and autonomic data. We have ECG, we have GSR, we have camera to look at their facial expressions, with the whole equipment minimally interfering with their ability to perform an actual clinical intake. And this is the pain task. The only thing I want to point the attention to is that we have two types of trials that we will call treatment and no treatment. So we are talking about evoked pain. We again use the cuff pain for the task, and electroacupuncture to like realize and model these two, treatment and no treatment of pain. And then after the pain task, as you can see in the timeline on top, we have the actual acupuncture treatment where no sensors were like placed on the patient and they just received care for their low back pain. All right, so looking at the clinical and behavioral outcome, we observed a lot of similarities with our previous fMRI studies. So first, the Therapeutic Alliance measured by the CARE score was rated as significantly higher by the patients in the augmented group compared to the limited one, proving a successful manipulation of the context. So we actually were able, through these instructions to the clinician, to have a very high variability in the Therapeutic Alliance within our population. And then if we look at the clinical outcomes, we also have this significant decrease in the low back pain for both groups. So once again, no direct link from the clinical context and directly pain perception. But similarly to what we found before, we again have like higher willingness to continue to see their acupuncturist and higher expectation for future pain relief. And also we use the PANAS score called like positive and negative affect schedule to measure their mood. And we saw this significant decrease in the negative affect after the visit only in the augmented group. So once again, there is a lot that is affected by manipulation of the therapeutic alliance. And for the neuroimaging analysis, EEG data come with 2 new signatures. So we are actually now able to differentiate between interbrain connectivity direction, which means if you look at the blue and the green arrows in this example, that we are able to assess what are the connections going from the patient to the clinician and vice versa. And this is only possible thanks to the very high resolution of this time series. InSec are actually able to extract results both at sensor level on the scalp, but also to reconstruct the cortical regions. And while scalp results are important for future real-time implementation, because of course they are very easy, like computationally, they are easier to extract. The analysis in the source domain was really important for us to make a comparison with other previous fMRI studies. So let's start from the sensor space. Here, what we found is that interbrain connectivity was enhanced after an augmented interaction. And here is represented like with the blue arrows compared to the limited group in yellow. And especially, we can see a significant increase of the connection between the right hemisphere, frontal and temporal regions of the clinician towards every other single region of the patients, which is a very interesting phenomenon because it's been already observed before in other type of dyads with their hierarchical order, such as mother and child, for example. So those results confirmed that the frontal and temporal regions in the right hemisphere which are like well known for this like high order social function and recognition of social clue, do have a regulatory role in this brain-to-brain networks established between patients and practitioners. And then we have the source spaces. So here we don't have electrodes anymore, but we went back to these like brain regions, which we reconstructed based on previous evidences from our fMRI study. And what we hypothesized here was like a higher brain-to-brain connectivity in the augmented group compared to the limited. But if you observe even just visually this comparison, we did not find initially this difference, surprisingly. So what happened is that when we then went to separate the network directed from the patient to the clinician compared to the opposite direction, that's when we actually found that difference in the brain-to-brain connectivity. And as you can see here, only in the augmented group, there is actually this significant increase in the augmented, so in the brain-to-brain connectivity, sorry. And in contrast, like if we look at this map here, there is basically almost no exchange of information. This is another way to talk about brain-to-brain connectivity, exchange of information between the two brains in the limited group. And thus, yeah, most of the area involved are still like social mirroring and nociceptive brain areas. And when then we went to separate the treatment versus no treatment conditions, we saw that these very interesting results was specific of treatment of pain and trials. And here is where we also found a significant correlation with the perceived pain analgesia. And the two measures here are just like two different expressions of the same phenomenon. So in one case, we're looking at the number of connections, which is a much easier like a measure to extract. And in the other case, we also wanted to give an idea of the intensity of the connection, so the amount of information carried by those signals. And then next we asked what regions were more involved in this network, with particular attention to temporal parietal junction based on our previous findings. And we found that involvement of the patient TPJ was higher in the augmented group compared to the limited, supporting TPJ as an important hub in these brain-to-brain networks underlying the patient-clinician interaction. And if I did not convince you yet that TPJ is a relevant area for this therapeutic alliance, we also obtained like this correlation between the degree of involvement of TPJ and therapeutic alliance measured as a care score. And yeah, this brings us to my last slide, which is like what's next, which is really exciting. And basically, so we found with both our neuroimaging projects that TPJ is a really important area. We also know from a lot of existing literature that TPJ is a key node in the network based at the basis of theory of mind and mentalizing process, even more than what is based on empathy. And so this brings us to our next question, which is, can a theory of mind training for fibromyalgia patients or chronic pain patients increase the therapeutic alliance, increase like a patient to clinician TPJ concordance, and eventually improve clinical pain outcome? And this is the R1 that we are working on right now in the lab with PIs Vitaly, Napadow, and Robert Edwards. And this is like a timeline of the experiment. And you can notice how it's very exciting. This time we have fMRI, hyperscanning, and EEG hyperscanning data collected from the same diet. So we are really curious to compare even more closely the results that we can obtain. So very, very shortly, we understand the importance of using two-person neuroscience and hyperscanning to model the whole system composed by patients and clinicians. We noticed manipulating the clinical context that is not directly linked to pain analgesia, but affects many other aspects of pain experiences, such as pain catastrophizing, mood, and adherence to treatment. And brain-to-brain connectivity is a good measure of that correlates with the different levels of therapeutic alliance and shows how TPJ and very specific area can actually be modulated in this way and hopefully can be used in the reverse way to improve clinical care. And with this, thank you so much to like all my amazing team that made this like very challenging projects possible. And yeah, thank you all for being here.
Between myself and Giulia Corniani. And what amazing first two talks, so thick and rich with lots of ideas and data. This study is going to be quite different. This is a really tiny pilot study, but I think it still illustrates a nice example of this sort of synergy between an important clinical question or clinical questions and the use of technology. And the two questions that we're really asking are, can we deliver Tai Chi to these populations that Brad's talking about in a virtual environment? Just like it's difficult to come into the lab to do testing, it's even just as difficult to come in on a regular basis to do these trainings. And then the other question that's always been interesting to me, and surprisingly not at all developed in the literature, is in these non-pharmacological interventions, what's a dose? And typically a dose is thought of as how much time you spend doing these practices, how many classes did you go to, how many minutes. But the fundamental question is, are people actually getting better in their Tai Chi? And does changes in what we might call proficiency of Tai Chi correlate with clinical outcomes? To my understanding, this has never been published in the literature. So this is a really small study that introduces this question. I'm going to talk a little bit about the clinical feasibility component, and then Giulia is going to do some really interesting stuff around whether we can automate this using wearable sensors and machine learning. Thank you for your patience, everyone. So you've heard the setup. This is a very simple pilot study to start with, and I'm going to go quickly so that we can get to some of the really interesting accelerometry and machine learning data. But there'll be two parts. I'll just go over the broad aims and design of our pilot study, and then talk about this video assessment by Tai Chi experts of proficiency and learnability of this virtual Tai Chi program at home. And then I'm going to pass it over to Giulia, who's going to talk about how we might automate this and use machine learning to support that. So the goals of this pilot study, this is a joint study between the Motion Laboratory that Paolo Bonato, who's here earlier, runs, and Giulia is part of, Biosensix, a company in Boston, and the Osher Center. And this was really a pilot feasibility study. Is this program feasible, acceptable, and safe for delivering Tai Chi at home? Can we evaluate changes in proficiency using video-based metrics over a 12-week period? And I'll tell you how we did that. We have one of our goals is to obviously monitor clinical outcomes. This data is not only a small data set, but it's still preliminary, so we haven't analyzed most of the data. And then can we use machine learning and accelerometers to automate that? Okay. So this was a single-arm longitudinal study, And there were two populations. The main population here were cognitively intact older adults. And we had 27 of those in our study. And then we also wanted to add a sample of people with mild cognitive impairment. Our goal was much larger, but we ran out of time and funding. And so we're just going to show you this preliminary data for the sample that we have as a proof of concept. The intervention, this is called Tele-Tai Chi, was a 12-week intervention. It had trainings that were divided into 3 phases, so people can watch videos for the first 4 weeks, the second 4 weeks, and the third 4 weeks that were progressive. One of the instructors who did most of the videos is on this image here. They were pre-recorded, and there were 6 Tai Chi elements and some preliminary warm-ups and cool-downs. And in addition to this sort of asynchronous learning at home, they met with the Tai Chi instructor twice over the course of the 12 weeks. The platform that we used included tools to deliver the intervention, to measure proficiency, both visually and with accelerometers, and to assess outcomes. This is one of our research assistants, Dan, and he was a big part of the study. One of the biggest challenges is this is the box. This is within the box that someone who signed up for the study as an older adult would get. One of the biggest challenges is how do you pack this stuff and send it to people and not overwhelm them. But the hardware included a large tablet, some wearable sensors, a tripod, and an iPhone so that we can be recording them from a distance, and some other hardware as well. By and large, especially for the non-NCI piece, this seemed quite feasible. We thought this might overwhelm older adults who were not used to technology, but by and large, we had no trouble recruiting the main population. The retention in the main population was quite good. Only 7% of the people dropped out over the 12 weeks. They actually did a lot of the practice that we can monitor at home in terms of the time that they spent. And then they scored the usability of the system. And most of them rated it pretty high in both groups. We had some qualitative things. I won't go into that for time here, which supported that, but there's a poster by some of my colleagues here that you should go see that emphasizes the qualitative pieces. Okay. So in terms of quantifying proficiency, this is something that actually happens. It's a little unusual to people think about Tai Chi as a very personal thing, but there are Tai Chi tournaments, just like there's ballroom dancing tournaments and there's figure skating tournaments. And the judges stand on the sidelines after performance and hold up a sign saying 3.8 or 2.6. And so we began thinking maybe we can borrow some of the tools from these tournaments, and it's a very established system. And so that was our baseline. And then we adapted it to our program and we proposed a scoring system. And we brought together a group of expert Tai Chi experts, biomechanics, researchers, and went through this sort of validation process for this instrument. And at the end of it, we had a pretty good instrument that we believed was a good place to start for measuring what we call proficiency. We had multiple domains in that proficiency, like can they basically do the sequence in the right direction or the choreography, but also just what's their posture like, their periods of doing and relaxation, we call yin and yang. So we had very clear criteria for doing that. In the data that Giulia is going to show, we had multiple instructors observe that, and we had very high inter-rater reliability, over 90%. For people watching the same videos. And we applied this to 6 Tai Chi movements, and we came up with one global score for the purpose of this study for each person for each movement. So that's the data I'll show you. And like I said, this seems like a really obvious thing. Are people getting better? You would think that there's a correlation between how much better you get and your changes in clinical performance, but people haven't done this. This is basically shows that for the 6 movements we did, one's called raising the power, push and withdraw, wave hands like clouds, very traditional Tai Chi movements, that between baseline and follow-up, people actually improve. So this supports, again, very preliminary data, small sample size, but that there's learnability. What you can also see in the finer lines is that there's variability in how people learned, both across people and which moves they got better and worse in. I think this is really useful not only for research, but for teachers. Who's learning, who's not, who needs a little bit of help, that sort of feedback, right? And also we think ultimately this could be good feedback to the participant, encouraging them, oh, you're doing really well with this, but you need to work on these elements. This is the last slide I'll show. which is very preliminary. But on the left panel, you see what's called single leg stance time. And it's a very simple measure. How long can you stand on one leg and not lose your balance? And what we see is that the people who increased in proficiency the most had the greatest improvements in single leg stance time. Timed up and go is the opposite. How long does it take for you to get up, walk, and come around a cone and sit back down? So it's more like a dual tasking thing. And what we saw were people who did the best in terms of improving in their Tai Chi had the greatest reductions in that. So then the real question is, for this conference is, can we take these visual assessments of a performance and automate them so that we don't need to be recording with visuals and then analyzing these, but can we automate that process? And that's where my colleague Giulia is going to take over. Is this in your way? Do you want to switch?
Okay, so thank you, Peter, for setting the basis of my presentation. I'll try to screen. Okay. So we now have this platform for Tele-Tai Chi, and our question is whether we can empower this platform with the ability of automatically assess how people are training and how often they are training. And in particular, we want to track adherence, meaning which exercise they are performing, and proficiency, so how good they are doing when they are training. And we want to use machine learning and the data coming from the wearable sensor for building up a framework for automatically assessing adherence and proficiency during the Tai Chi training. We came up with this pipeline, and during my presentation, I will go to drive you through all the steps that came up with this pipeline. So we collected data from 32 healthy participants. We had participants coming in the lab, and we made sure to cover a wide range of different Tai Chi experience, going from more naive participants to more expert ones, and data were collected in a single session. We follow a protocol that was very similar to the protocol of the longitudinal study. So we asked participants to perform 6 different Tai Chi movements, and we asked them to repeat each movement from 6 to 9 repetitions. We collected video with cameras, so we had video recordings of the performance, and we also had 13 IMU units strapped around participant body on both arms, on the trunk, and on both legs. The 13 units were shimmers sensor embedded with accelerometers and gyroscopes. Video recordings were assessed by 2 Tai Chi experts. We asked them to score the gross competency, meaning how well the Tai Chi choreography was performed by participants. And we asked them to score in a scale from 0 to 5. And we then narrowed down this scale to 3 different levels to make sure that we had a balanced data set to then train our machine learning model. We used the proficiency score provided by the Tai Chi expert as the ground truth for training and assessing the performance of our machine learning model. With the IMU data, we performed first traditional processing for remove noise and artifacts. Then we segmented the signals into the repetition of each movement. And as you can see from the plot on the screen, we use the shape of the signal for identifying the different repetition. Then we use a low-pass filter to extract information about the pose and the posture of the body segments, and a band-pass filter to extract information about this flow and the smoothness of the movement. We characterize our signals with almost 400 different features, both in the frequency and in the time domain. And we use features such as the dominant frequency, the peak amplitude, and also the cross correlation between the signals coming from different sensors. Then the first thing we want to do is to assess which exercise is being performed based on our sensor data. So we built a movement identification model. We selected the most relevant features for our task, and we use a random forest classifier for building our model. We want to track adherence because, first of all, we want to assess which exercise the participant is performing and if they are following our protocol, but also because later on we want to build movement-specific proficiency assessment.
Our movement identification model overall performed pretty well. We had a micro-1 score of 90%. And as you can see from the confusion matrix here on the bottom right of the screen, the model was pretty robust in identifying which exercise was performed. There were some error in the grasp the sparrow's tails and wave the hand like clouds movement identification. And this is probably because these two movements share some common pattern. And for this reason, our model was struggling a bit in taking apart these two different movements. Then once we have the movement identified, we can build a proficiency estimation model. And we are doing that specifically for each movement to be sure that we can capture the feature that mostly characterize the proficiency for each different movement. So we had 6 different proficiency estimation models, and they overall perform pretty well with a micro-1 score of, on average, 73% across the 6 different models that we built. I reported here as an example the result for one of our proficiency assessment model. And as you can see from the feature projection on the bottom right of the screen, there is a good clusterization of our features in the 3 different classes, so low, middle, and high proficiency. There is still some overlap here on the top left of the feature space. And this is probably because when we merge different classes, we include a lot of variability. And so our model is not completely able to explain the full variability within one single class. So in conclusion, as Peter showed you, our tele-Tai Chi platform is well received by our study population. And throughout the study period, we found some improvement in the Tai Chi performance. And we also found preliminary evidence that improvement in Tai Chi technique is somehow has a relationship with changes in clinical relevant metrics. On my side, we show that we can use wearable sensor data for assessing proficiency and adherence to training protocol. And this approach is particularly promising because it offers an objective tool for monitoring training progress, and it can potentially be applied also for other movement-based intervention. This concludes my presentation. Thank you everyone for listening. Thank you, Peter, for the opportunity of presenting, and to all the collaborators on this study.
All right, will all the speakers please make your way up to the front here? So I know we're running a little bit behind, but so we might have to cut a little bit of this time short, but I just want to hope that you all really appreciate this sort of fascinating work that's being done. Really, this panel kind of highlighted the multiple facets of how we might consider using technology to inform body-mind, mind-body connection. So, you know, not just using technology as an innovative way to deliver or augment or to track the mind-body interventions, but also using tech to facilitate the outcome, you know, assessment. And I think maybe more importantly, or most importantly, to fundamentally help us, you know, inform and advance kind of our understanding of the mind-body connection. So I hope we'll get to hear some insights here. So I'm gonna ask, so it was supposed to be 25 minutes, but because we're running behind, I'm gonna ask for at least 15 minutes, and let's see how far we can get. What I propose to do is I have some questions, and I'm also welcome questions from the audience members as well, but I think I'm gonna ask a question to each of our speakers, sort of specific to their own presentation, but if others want to chime in for any discussion, that's fine too. And then I have one question that I would like to pose to all of you and for some discussion. So let's see how far we can get in 15, 20 minutes. All right, so the first question is to Vitaly, actually. You know, it's really fascinating to me to sort of think about the vagal system, you know, the vagal nervous system as that window into, you know, into mind body. And I'm really struck by the, you know, that one slide where you had all the different organ systems that are affected, right? So the vagus system is really kind of just deep and embedded in the whole body. So I'm wondering, given your your training actually in TCM and acupuncture, do you see like links between the vagal system and principles of TCM, like thinking about parasympathetic and sympathetic and yin yang, for example? Like, any thoughts about that?
Yeah, it's an interesting point, and I think one thing that is coming across as more and more research in neuromodulation is happening is that there's a lot of links in neurology between different nervous systems that we didn't know about, previously, even like in the biomedical sphere, biomedical health sphere. And so I think in understanding how these different, like why do certain areas of the body might connect to different organs? Like, it's really not clear why that should be, or why is there these microsystems, say in the ear, where supposedly different organs are demonstrated in the ear? Where if you look at these very old maps of ear acupuncture, and you look at the area that's innervated by the auricular branch of the vagus nerve, it's a lot of these deep organs that are in those areas where, I think you could argue that there's no way that, ancient practices knew that there is this branch of the vagus nerve that's exiting out to that area. So I think there's a lot of links that are there, and maybe just from a empirical instead of a physiological pathway, cultures develop this like understanding of different body areas and what they can be useful for if you stimulate those body areas. And I think there's a lot of lessons to be learned there. So this is just one example of that.
Yeah, I guess maybe a corollary to that is, are we missing anything by focusing on the vagus system?
Well, we're missing everything that the vagus doesn't integrate, I guess.
Yeah. But in
But,
terms of thinking about mind and body connection, I guess.
Yeah. Yeah, I think a lot of times people think about the vagus and they think about how it's this controller of the heart and heart rate. It's this controller of gut peristalsis and things like that. But actually, if you look at the nerve itself, the vagus nerve, it's 80% afferent, meaning that 80% of the traffic that happens along this nerve is actually going up to the brain from these organs, not the other way around. So it's really this kind of like sensor that's there, like for the viscera of the body. And that's a really important function of the vagus that I think we have to pay more attention.
Lot to think about. All right, Brad, for you, well, I have one quick one and then maybe a lengthier one, but let's, how about this one? So have there been any specific mechanisms identified through which Tai Chi or other mind-body interventions improve dual task performance?
I think sort of yes and no. I think, first of all, we're right at the very beginnings of understanding if Tai Chi and the extent to which Tai Chi can improve dual tasking. I think there are some really nice preliminary studies and more every day, but I still think we have to answer that question. With respect to dual task gait, through other research, we've been able to identify very specific brain regions and large-scale brain networks that seem to be very vital for dual task performance. And if we use things like transcranial neuromodulation, targeting those networks, we can improve dual tasking. And in particular, the frontoparietal control network seems to be very important, which is a network that is, maybe you can think of it as like the conductor of the orchestra of the brain, involved in many different high-level executive functions, and it seems to be vital for dual tasking. And I think there's other work to suggest Tai Chi can improve the functionality of that network, but we have yet to piece the two together, which we should in future grants together.
All right, seeing nothing from the audience, I'm going to keep on going. All right, so for Peter and for, oh, is there somebody? Oh, yeah, please go ahead. Yeah.
I did have a question for Vitaly. So two quick questions. One is regarding the 100 hertz frequency. Why that, any thoughts on the underlying mechanism for why that would be? And then the second question is regarding the effects of certain acupoints like stomach 36, PC6, that has been shown to regulate or activate vagus nervous system, and how the effects of stimulating those points may be different from the vagus nerve in terms of the frequency as well. Any thoughts?
Yeah, good questions. I'll start with the second one just because it's easier, and the answer is just we don't know. We haven't directly compared, vagus nerve stimulation to pericardium 6, which is here, forearm for those who don't know. We just haven't done that comparison, so we don't know. The 100 hertz question, this is like a beautiful example of why you have to actually do the research and not just write theory papers, because it was the complete opposite of what we hypothesized. Most vagus nerve stimulation and those devices are happening at around 25 to 30 hertz for stimulation. And so we a priori hypothesized that, 2 hertz would be okay and 100 hertz would be okay. But really where we would get the best results is at 25, 30 hertz, like this kind of like inverted U-shape distribution. And we got literally the complete opposite. We got, some response at 2 hertz. We got very little response at 25, 30 hertz for some reason. And we got really strong response at 100 hertz. And I don't know why that is, but it was the complete opposite of what I think we hypothesized a priori. It might have to do with the fact that we're not stimulating continuously, that we're stimulating with this like periodic intermittent manner with RAVANS. And so that might be the important function, but it was surprising, but that was what the results showed.
Tested higher frequency to above 100?
No, we didn't go because the previous assumption was that 100 hertz wouldn't be that effective.
Art?
Hi, this is for Vitaly. Very practical question. People come in to me and ask, gee, how do I get a vagal stimulator? What should I look for? Is there an exact recommendation? Can you fill in some answers there?
Well, the technology we're working on is not yet commercially available. So we're working like well within the medical system through the FDA and everything like that. And so I'm not actually a part of that, but there is an entity, Cal Health, that's working on that technology. But you can go on Amazon and you can get vagus nerve stimulators, and some are probably better than others. But this stuff is already out there, like it's already available. People are hacking into their own bodies. Stuff.
Right, but what should a person who's looking on Amazon look for? What?
You should look very carefully and cautiously, and I really hesitate to endorse any one thing that's available on Amazon.
I think maybe Art, you can maybe talk with Vitaly afterwards and give you his recommendations.
Okay.
All right, very briefly.
Quick question for Dr. Manor. I saw that you had said something about at 55 years of age plus, there was this breakdown for dual task walking. What do you suspect is going on there? And was there a gender difference as well?
First, there was no gender difference. We did some mediation analyses and able to demonstrate that I think it was 60% of the variance in dual tasking after age 55 was explained by differences in executive functioning as measured by traditional pen and paper tests. So I think this idea of dual tasking as it relates to gait is really a measure of executive function. And I think there's been quite a few studies suggesting that's right about the time where executive functioning declines as well.
I would just add to that, and tomorrow, CK Peng and Andrew and others are going to be talking about TCM and complexity capturing cross-organ communication or sort of like holographic measures within one physiological signal. And 50 to 55 is where you see this inflection point in heart rate variability starting to go down, in gait variability, which might have some link to dual tasking in other physiological signals. So things that crosstalk seems to be affected sooner than individual signals. But that's a key point.
Real quick follow-up. Does that mean you can train it? Like if you practice that more before, can you stop that breakdown?
I think Brad said we don't have enough data. I would think, the latest paper by Fuzhong Li, they're getting into trials with 300 plus people. And then there's enough of them around to suggest that these mind-body practices may be able to influence this sort of cognitive, motor, executive, top-down, bottom-up. But I'm being a bit more generous with the evidence than Brad is, but I think we definitely need more data. But I think it makes sense, and I think there's some trends that support that, but we definitely need both more clinical data and mechanistic data.
All right. Peter, and I'm going to try to get some more questions because I have a couple of questions for this side of the panel. So Peter and Giulia, I wanted to ask about, sort of more or less sensors. So the question is, what have you considered sort of other types of wearables like ECG, EEG, or respiratory stuff to actually augment, what you've been doing? And is that needed? Like, what more is needed maybe to sort of really learn about whether a person practicing Tai Chi, is really, in the moment and mind and body both there, and at the same time, like, can you strip away stuff? Like, is just the video enough? Like, looking at the ambient device that Dr. Katabi talked about, like, is that enough?
Okay, I will start from the second one, whether we can remove sensors. So the answer is yes. In our cross-sectional study in the lab, we used 13 sensors, but from our analysis, we found that already with 6, so 1 for each limb, 1 for each leg, and 1 on the trunk would be enough for having like very similar results. We also did a very similar analysis with just video recordings and doing motion tracking from video data. And that's feasible when we have data from lab environment. So people coming to the lab and like standing in front of the camera in the lab. When we go into the home setting, everything gets very much complicated because, for example, in our longitudinal study, we have recordings from people in the home setting doing Tai Chi, but we have all kind of occlusion, for example, the cat coming into the room and sitting right in front of the camera, and so we cannot see the practitioner anymore. So potentially we can do assessment just through video data, but we need first to face all these kind of complexities.
To the second part of your question about other physiological signals. And I'm just thinking about walking, and Brad, correct me if I'm wrong here, but one of the beautiful things about walking is that it's highly integrated. Just about every physiological system from muscular, neurological, cognitive are involved. But then you get this measure of how well someone functionally performs in a given environment. So it's holistic and it captures all the rich crosstalk. So it's a great measure. I think in some ways, Tai Chi performance is like that too. It's similar to walking. And then the question is, what would you learn about having a respiratory belt, a galvanic skin response thing, all these things. And I think what they would do is they would provide some insight into the mechanistic processes that lead to that whole person performance. So I think it's not so much whether it'd be a better marker of performance, but I think they would give really rich insight into the physiology and the cognitive processes that lead to a whole person performance.
I think this is what NCCIH really wants us to study, right? Like, how can we get the whole person in all of our measures? So I think, go ahead. I think this might be the last one, but I still have a great question for you, Alessandra.
He deserves it. He's retired now.
Which means I have plenty of time. There's been a lot of talk about the nature of the mind-body connection, and a lot of brain mechanisms have been outlined by you folks. But I'm struck by all these practitioners of traditional Chinese medicine, no mention of Qi, or the yoga practitioners, no mention of prana. What do you guys make of that? Because there are ways of assessing that, not as exact as these fMRIs, but there are AMI measurements and gas discharge visualization to sense whether, the question would be, you may move the correct movements in Tai Chi, but is your Qi actually flowing?
Great question. And a great one to end on.
I gave a talk, Rick, at our Tai Chi conference called "To Chi or Not to Chi," And it was an important question because I think in these early phases of this work, we're trying to build bridges between these traditional systems. And you can see from all of this amazing work, we're learning whether these interventions are clinically effective. We're learning about mechanisms. And in none of our work do we need to evoke qi. In none of my papers do I say this is because of qi. That being said, there is something about this paradigm that might enhance our understanding of what's happening and how to make these therapies more effective. And I think that's going to be touched on quite a bit tomorrow when we look at measures that really emerge out of traditional East Asian medicine diagnoses and some of Andrew's work about bioelectricity and sort of the biofield of the body. But it's a great question.
Anybody else on the panel want to comment on that one at all?
I think just fundamentally, it's difficult because it's such a important component of the education system. And when you go to Chinese medicine schools, and it's a big part of what you learn in all the different types of qi and things like that. But it's just hard because it's a philosophical construct, and there's translation issues from the original meaning of what it was in the culture that was there, and trying to bridge from the context of a certain culture that a certain word came from to the culture in the United States is difficult. So having said that, we don't have like a gold standard qi meter. We don't have anything that we know how to measure these concepts with, and so I think there's research trying to go in that direction, try to understand this better, but we just don't have that yet, and so we're operating with the tools that we do have, and that's where we're at right now.
All right, with that, I think I have to end. Let's give our panel one last round of applause.